Welcome to our viewers to another edition of our flash interviews UroVisa. So I'm here with Professor Stenzl, a very well-known urologist from the University of Tübingen and also Secretary General of EAU. So thank you, Professor Stenzl, for being here with us. So yesterday you gave a talk about the limits of the role of the limits of the AI in the urothelial cancer surgery. Well, so what are the main takeaways of your presentation?
Well, first of all, thanks, Frederico, for the invitation here and to be able to discuss that with regards to how can we implement AI and how dangerous it could be for urology, and especially in that case, yesterday was about bladder cancer. Well, the role is, of course, we cannot neglect artificial intelligence anymore, and we can definitely benefit from that, be it by better education of our young colleagues, by getting more information, for example, during surgery, but also how can we digest the immense literature which we have in urologic oncology and bladder cancer. And 8,000 papers over the last 2 years on bladder cancer. How can you really get a nice overview for your individual patient when you have them, when you have these patients in front of you? So it is something for the clinicians as well as for the young urologists, but also for the patients, because the patients need to be educated. They need to have a better understanding of the diagnosis and the possibilities of treatment. And that needs to be given the patient, especially before they come to your office or to your clinic, in order to discuss what is the strategy going to be. And that takes away some of the work, especially of the young urologists. And that is something where we can use AI for onboarding of the patient and get him to have more material for a shared decision making.
So that the AI seems actually a very useful tool for us clinicians to digest all that information and also to aid us in our treatment strategies, etc. So, but is there any data regarding the clinical impact, clinical outcomes, the improvement of clinical outcomes for the patient already, or
Yes.
we're not there yet?
No, we're there yet. Actually, unfortunately, not from Europe, but they come from the US. And in Virgil, for example, from USC, he brought up some data, and some data from Cleveland Clinic have shown that those patients that have already been informed beforehand with the help of AI, with the conversation based on AI with an avatar from the respective urologist, that these patients needed on average per patient per day 8 minutes less, which comes with 40 patients, for example. You can figure out it's a couple of hours less work needed to be done in the clinic by the respective urologist. So, and also there is more time than for the shared decision making. And there's other papers. Now that one is partially from Europe as well, that shows, for example, Cacciamani, well, he's working in the US now, but Iper, he's working now in Germany. They have shown that ChatGPT actually gives a better, or creates a better patient understandable language from research papers which we have in European Urology and other journals. You know, there's always a patient summary, but the patient summary we create as a doctor, or the consenting which we create by the doctors, is not as good as the one by ChatGPT. And that is something, you know, it's not that it makes us useless, but it just helps us to get the patient to a higher stage of understanding and better discussion than and of course save time.
So you foresee the future of AI in medicine much more with a mix of some replacement and augmentation and augmentation of the medical work.
Well,
So it's a mix
yeah.
of both realities.
Yeah, but the emphasis is not replacement. The emphasis is augmentation. The emphasis is giving more time for the doctors and better, more useful time, and not like having a repeating sentences talking to the patient, which could that could be replaced by AI. Giving the patient that information, so you don't have that repetitive things you tell every patient to make him understand what is bladder cancer, what are the options and stuff like that. He already has heard it already, and then he can really get into
questions, etc.
Ask questions about what is his personal situation. He is married. He has maybe his second wife, or he's a widow, or he has like certain things in life he wants to do. So sometimes it's the overall survival, and other times it's quality of life, which is more important. And all that stuff is important for the patient, because otherwise he will have, and we have data on that, he will regret after 5 years and longer that now he's surviving cancer, but now he's regretting the decision he made, which could have been different if he had known more based on his own personal situation.
Okay. So apart from this, you are, as I said, Secretary General of the EU. How do you see the relationship between the EU and the national societies like APU playing out in the future?
Well, I hope I see it well. No, but we are a European Association of Urology, and we are based in Europe. So the national societies of Europe, that is our biggest goal, to have the best relationship possible. To be able to support, for example, the APU, the Portuguese association, dealing in matters in Brussels, dealing in matters in a pan-European recommendation on early screening for prostate cancer, for example, on dealing with certain things that are related to, for example, geo-oncology. What can and what should the urologist in Portugal or other national societies being able to do in geo-oncology, so that they, or us, the urologist, is not only the one who does the surgery, but that is dictated by somebody else, that we are in the strategy making of a patient. And that is, we don't have to do certain things that are in the field of oncology, but we should be part of that strategy decision when it gets into multidisciplinary board, for example, that we have like point of care guidelines on your phone when you discuss in the multidisciplinary tumor board. That's partially AI, but it's partially also that we can provide guidelines that are recognized in all over Europe, and that will be recognized in a multidisciplinary tumor board when you're sitting with the oncologist, radio-oncologist, radiologist, nuclear medical guys, that you say, okay, for that patient, this is something that is in the guidelines, and that should be considered, and that should be part of the strategy for the patient.
So as a member of the direction of the APU, we are very pleased with working with the EU, and I hope this collaboration will strengthen in the future even more. So
yeah, absolutely. I totally agree. I think we have a good relationship, and as I already said, we admire the way you organize things, you handle things. It's very effective, but it doesn't look very stressful most of the time. So it's there's a way of dealing with important things in a very calm but still not stressful way. Congratulations for that.
Okay, thank you.
Yeah.
Thank you, Professor, for the interview. Okay, thank you.